Thank you, Dr. Randall Feingold, for joining us again to another episode of Wednesday Wellness with Leora. Let's cover first your meeting with the Safety Committee with the American Society of Plastic Surgeons.
Hi, Leora. Thank you for having me here. Every year, this time of year, the American Society of Plastic Surgeons has a meeting of the Patient Safety Committee. And as a member of that committee, we look at various issues in surgery impact the safety and health of our patients to come up with guidelines for all of our patients. Several practitioners spoke on a variety of topics, and my topic, as you would guess, is about best practices in breast implant surveillance and helping our patients identify and manage implant-related complications, because I see so many patients with pain, implant ruptures, contractures. I've identified a variety of malignancies of breast implant capsules as a result of doing capsulectomies, and some have systemic symptoms. Obviously, our patient population that listens to these podcasts are aware of this through social media or advocacy groups and all types of champions out there. One part of the discussion was about the FDA position about needing to make the public better informed before having breast implant surgery, and not just implant labeling, but the patient decision checklist that requires that patient sign off and initial numerous pages of informed consent so they understand a variety of issues related to implants, and that they have proper imaging every 5 years or 5 years after implantation and every 2 or 3 years thereafter. And they go through concerns, not just bleeding, infection, but also breast implant-associated lymphoma, systemic symptoms we call breast implant illness, the fact that implants have a limited lifespan and will require reoperation in someone's lifetime, that implants rupture, they have gel bleed, you can have silicone migrate unretrievably to lymph nodes or other organs, and the need for surveillance. So the FDA did ramp up, but there are shared responsibilities about examining patients that are dependent upon patient and physician compliance. And that's really my concern that I brought to the committee, that regardless of the examination and imaging recommendations, there are women under 40, they're certainly not getting imaging for breast cancer surveillance. And I wonder how many, if any of them, are really undergoing imaging of their implants on a regular basis. The women over 40 may be getting breast cancer surveillance, but that doesn't mean they're being as compliant as they could be. And the compliance issues are on the part of patients, but it's also on the part of doctors. They shouldn't just put implants in, happy that the patient looks good after a couple of months, and say, have a good life. They need follow-up. And unfortunately, physical examination may not detect complications. I can't tell you how many times I've had the unexpected finding of ruptured implants in women that I've operated on for a variety of reasons who had normal breast imaging results, whether it's ultrasound or MRI. And it makes it difficult to counsel patients about whether they're really, safe. And so I discussed a whole bunch of scenarios of these unexpected ruptures, sometimes in the capsule, sometimes outside the capsule, with unfortunate silicone migration to lymph nodes, the severity of contractures and calcifications in the textured implant population, even if they don't have ALCL, the unexpected capsular B-cell and T-cell lymphomas I've discovered, and of course the bacterial and fungal colonization that we find in many patients. And one area of controversy remains the lymphoma that's associated with textured implants. How are we supposed to counsel patients? Data from Memorial Hospital says 1 in 300 risk at 10 years, maybe 1 in 100 risk by 20 years. Should we be waiting for cancer to develop in these patients? Should we be doing preventative operations to remove their capsules? My feeling about that, I'd rather err on the side of intervention. I don't really want to treat a capsular cancer if I can prevent it. And so the thrust of my presentation was, there are so many opportunities for improvement. How do we reduce mutual neglect amongst patients and providers to increase surveillance? How confident can we be that we know how to predict or identify these complications that are sometimes missed by imaging studies? I think capsules should always go to pathology evaluation. I don't know that's a national standard, however. So I would love to see patients with implants have annual exams, regardless of how good they look or feel. The question of preventative maintenance is undecided as well. So many patients come in and say, my implants are 10 years old, and so I was told they need to be changed. And when you're not an automobile, you don't need an oil change every 10 years or 10,000 miles. I used to dissuade patients earlier in my career from changing their implants automatically every 10 years, but now I'm not so sure. I'm not sure that I trust implants that are 7, 10, 15 years old, and I do think patients need examination. I think they do need imaging studies, and we have to do a better job of identifying complications of implants in women, because I see so many women coming in with complaints. And so explantation is my focus, but I can only treat the patients that I see. And I'm just concerned there are many women walking around there with unsuspected complications, or they're living with complications and they're not getting close follow-up with a plastic surgeon, whether it's their original plastic surgeon or not. And I think everyone in attendance, everyone at the committee thought this was like a useful conversation to remind us not to get complacent and that patients with implants need monitoring. Not everybody on the committee or in the audience has a practice that's as focused on this as I am, but everybody agreed that this is an important conversation.
What are still the best practices for women to monitor their breast implants?
Well, one obvious symptom is pain. That can be from muscle spasm, but it could also be from capsular contracture. And if a woman were to look in the mirror and see that a shape has changed, that suggests that the scar capsule around the implant has tightened down and moved the position of the implant or deformed the shape of the implant. That alone may motivate a woman to seek a procedure to correct it, but sometimes the contracture itself is a sign of an implant rupture, because the rupturing of an implant, the exposure of that gel within the body, can stimulate the contracture. So some contractures may be spontaneous, some contractures are induced by rupture. So that's an indicator that there may be a rupture present as well. We have patients that have swollen lymph nodes in their armpit, and I hate to say it, sometimes even in the neck. That's a real warning sign. And it could be caused by many different things, of course, that may or may not relate to the breast or to the implant. But self-examination is important, self-awareness is important, and whether you have pain, contracture, swelling, I think you should bring it to your doctor's attention. Even if you have systemic symptoms that you're uncertain as to their origin, headaches and brain fog and visual changes, hair loss, skin changes, joint pain, you name it, it's worth going to a doctor, making sure that there aren't endocrine causes or infectious disease causes or autoimmune causes behind it. And if there is no classical illness to explain it, then maybe get to the plastic surgeon and say, I've got symptoms, nobody can figure this out. Please look into this for me and tell me, is this related to my implant? And of course, have an awareness of what your implant is. Hopefully, people are given the identification card at the time of surgery so they know what type of implant they have. And if they have a textured implant that's in the category of being recalled because of the association with lymphoma, then you have a heart-to-heart conversation with their plastic surgeon about, are we just watching this? Are we getting imaging? Do we want to just remove the capsule because we know that's where that cancer forms, and there may be therapeutic value in removing both the textured implant and its capsule? These are the things women should be thinking about. I'm not trying to scare anybody, but in order to maximize everybody's health or treat complications at an earlier stage, we need awareness on the part of patients. And we need awareness on the part of plastic surgeons, which is why I gave this book.
So when you do the explant surgery, during the explant surgery, do you get a chance to examine the lymph nodes, or do you have any kind of ability to determine whether they are enlarged or they are normal?
So examination of lymph nodes regionally in the armpit area, we call that the axilla, or above the clavicle in the supraclavicular area, the neck, that happens during examination in the chair in the office. It doesn't require going to an operating room.
Your patient are actually being examined when they are coming for a consultation just before the surgery?
Well, I think when I first meet patients, I examine their breasts, and we look for shape and symmetry and firmness and rippling and evidence of contracture and swelling of the chest wall and swelling of lymph nodes. This is fundamental examination that could or should be done at first visit and can be redone at the time of surgery. Imaging studies will often show surprises in the armpit area. I've had patients that have a report on an imaging study of silicone in lymph nodes in their armpit, but when I operate on them, I don't find a leaked implant. But yet that silicone made it through through the wall of that implant, through the lymphatic channels of the breast and drain to the armpit.
Yeah.
The fact that an implant is intact, yes, that makes us feel better, but I've seen migrated silicone even with intact implants. But I can't really remove an implant that's swollen or felt to contain silicone for fear that's going to cause interruption of the lymphatic drainage of the arm, and that would be called lymphedema.
Yeah.
And that may not be treatable, and that has its own symptoms or other complications.
So I'm going to ask you a question that I think that some women will probably ask that question. When a woman go to have a mammogram or ultrasound, are these lymph nodes being examined as well?
Yes. I think that mammogram and ultrasounds and MRIs of the breast routinely look at the lymph nodes in the armpit area, not deep in the chest, not in the neck, that you might see on an MRI, but mammo and sono do comment on the status of lymph nodes, their size, if their shape is normal, and they can often comment about the presence of foreign material within the lymph node that would be suspect for silicone.
Yes. So is it very common? I've seen quite a few posts in the larger groups of women with breast implant illness that are saying that they have enlarged lymph node. Is that normal? And then you see about 50 comments, and women will say, oh yes, I had it when I had my breast implants. And so I do want to say that when I had my breast implants, that was like in 2009, I went to a routinely checkup, and my axillary lymph node were swollen. Obviously, the doctor freaked out, and I sort of knew that it wasn't cancer. I just knew it, but I was rushed to have a biopsy and a mammogram and ultrasound, and it came out as fine. Everything was normal. Obviously, not every enlarged lymph node is cancer. It can be also a reaction to some kind of inflammation or reaction to a foreign device. That's a question mark, of course, I'm asking you.
Oh, and you're correct. The vast majority of swollen lymph nodes are what's called reactive lymph nodes, and they are responding to any number of things: a foreign object, inflammation, infection. You could have a viral illness or a cold and have lymph nodes throughout the whole body swell or be tender. We're all kind of familiar with that when you get a sore throat and you can feel swollen glands in the neck. A woman with breast implants can have swelling of lymph nodes in their armpit area, and that definitely does not lead us to the conclusion that they have ruptured implants.
Yeah.
But it's something that you want to rule out.
Yeah.
Because even if the majority of swollen lymph nodes are reactive, you just don't know until you do a little more detective work, what the cause of that is. So it could be a warning sign.
So last question on the enlarged lymph node. What is the proper exam to do to check not just the axillary lymph node, but also I know that the pathway of breast lymphatic drainage, one is the axillary, the second one is the internal mammary gland, and then we have the transpectoral. What kind of testing will actually look into this lymph node just to see if there is maybe silicone, why they are enlarged also?
When women are given instructions on breast self-exam, for detection of breast cancer, which is a good monthly thing for women to do for health maintenance.
Yeah.
They're taught to examine the breast, but also to feel in the armpit area for swollen nodes.
Yeah.
You would never be able to detect foreign material or a cancer in the internal mammary lymph node chain,
which is along the
rib cage next to the sternum.
Oh, it's here?
And it's not accessible. It's to the right and to the left of your breastbone, the sternum, but it's just deep to the rib cage.
Yeah.
Now, because I've had a lifetime of experience with breast cancer reconstruction and women who've had mastectomies, and I'm a microsurgeon and I focus on natural tissue reconstruction. When I transplant tissue to build a new breast, I reattach the blood vessels of that transplanted fat to the internal mammary artery and vein. And so I see those lymph nodes all the time in the operating room when I do those operations. And every time I see them, I sample them and send them to the hospital pathology department. And I've had a handful of cases over the years that have had unsuspected breast cancer in them, in women who've had current or past breast cancer, and it was undetected at the time of their breast surgery when the lymph nodes were sampled in the armpit. And for the women that I explant after they've had breast implant reconstruction after mastectomy and substitute natural tissue to give them a safer and warmer living breast reconstruction, I will sometimes find silicone fragments in that internal mammary lymph node. So the breast drains very much to the armpit, but also can drain to the internal mammary chain, and occasionally, more infrequently, to lymph nodes in the supraclavicular chain and cervical chain in the neck. Once the horse is out of the barn, it can travel in...
You don't know where it goes to, actually.
I'm sorry?
I said once it can travel to different pathway, not just to, I understand, not just to the lymphatic nodes.
It travels through lymphatics to lymph nodes, but theoretically you could find it in other organs, and that has been reported as well. I've seen silicone in human breast tissue, even with saline implants when they don't have silicone gel, and it's related to shedding of silicone particles from the shell of the implant. So when you embed foreign material, there's always a chance that it can break free and travel and maybe cause symptoms for patients.
So is there any way, just before we close that discussion, to avoid being in a position that silicone is moving out of the capsule into your system? What are your recommendations to them?
If you're worried about silicone leak or silicone migration, remove the implant, because we don't know how to predict which implants will leak or in what time frame. I just removed a pair of implants from a woman who, she's a local woman, but she had surgery in Dominican Republic many years ago, and reportedly intact on the imaging study, and they were apparently intact when I removed them, but they had this kind of a slimy, slick coating on the outside, greasy, that's consisted with silicone gel bleed, where it's kind of migrating or moving by osmosis somehow through the shell, technically intact, but yet the gel has found its way through. Most women don't have ruptures, but it's probably 1% a year, 10% by 10 years, but the material science is not secure enough to give you a hard number of years so you're going to be safe. And the same surgeon putting in 2 implants in identical fashion can discover many years later that one implant appears perfect and the other one is completely disintegrated. So the only way to prevent rupture or migration is to remove an implant.
I can hardly breathe when I think about it. The kind of risks that we take because we have no awareness and because we don't have enough information about the risk that are associated with breast implants, and maybe then you want to think twice, 3 times before you move forward. We have other options now. Maybe you want to just mention them, which is breast lift as well as fat grafting. I
operated on a woman today who sought breast augmentation from me a couple of years ago. She lives in another state. The operation that I performed for her was fat grafting, autologous fat grafting from her own tissue with an implant. She had a couple of stages, and she's grown from a B cup to a C cup to a D cup through stage fat grafting with no implants. So for some women, there are natural tissue solutions, but I do understand that there are powerful drivers that many women will seek breast implantation, and whether it's having a slight figure and identifying a larger breast with femininity and sensuality, or whether they suffer the loss of a breast because of breast cancer and a mastectomy. The bottom line is implants are still being used. Implants are sought after by many women. Plastic surgeons can make decisions whether they do augmentation or reconstruction with implants or not. But at the end of the day, patients have to make informed choices and
definitely
need information to make that choice. And then once a patient has an implant, they simply should stay connected with their plastic surgeon, have an annual exam. It may seem like a little bit of a task to go there once a year, but let another set of eyes look at them, let another set of hands evaluate them, get proper imaging at the right timetable as the FDA recommends, and let's not forget about these simple basic things that will allow women who do have implants to detect complications at the earliest time, So they're less likely to have big leaks. They're less likely to have implant migration. If they've got textured implants, perhaps we can mitigate their risk of developing these uncommon but real cancers of the capsules. And for women who have symptoms that can't really be diagnosed through other classical diagnoses, to consider removing their implants and their capsules, because as the FDA acknowledges, there is a symptom relief associated with that. So that's a long answer to the question about my presentation at this meeting, and hopefully that's information that will help somebody out there better manage their implants.
I think that just one thing that I wanted to clarify and to highlight, because I think women with breast implants, before they decided they want to explant, obviously, it's not clear if they should go to the OB-GYN for a breast check or to the plastic surgeon, or they should do both. And I know that in certain countries in the world, you are required to do mammography and ultrasound. If you have breast implants, I certainly did once a year. And once a year, I also got my breast checked. But I never went to see my plastic surgeon. As a matter of fact, the moment I was done with the surgery, I never saw him again. So the question is, are you supposed to see an OB-GYN, a plastic surgeon, both maybe? What is the best practice?
I think that plastic surgeons who are familiar with inserting breast implants and managing the complications of implants are the best examiners for ongoing surveillance of patients with breast implants. It's what we do, it's what we know. We can't expect other practitioners, whether it's the primary care doctor or the GYN, to have our knowledge base or experience or expertise in this fashion. So I think best practices would be to follow up with your plastic surgeon. And hopefully your plastic surgeon feels enough of a connection with the patient to want to follow them and make sure they're okay.
That's really great information. And I want to thank you again, Dr. Feingold, for sharing with us this important information and anything that has to do with our patient safety all over the world. And for our viewers and listeners, if you like what you're hearing, please subscribe and like our episode. Thank you so much.
Thank you, Leora.
Bye-bye. So here is the questions. Surgical drains or no drains during explant surgery?
Is that a question?
It is a question. Actually, I've seen many women who says that it's not convenient to have drains, and they have small babies and they rather not have drains.
None of my patients want to have drains, no matter what breast operation I do, whether it's breast reconstruction or breast reductions or explantation surgery. And I'm not married to using drains in all circumstances. Personally, I don't use drains in breast reductions, but I have partners and I know many quality plastic surgeons out there that always use drains in their breast reductions. But after 31 years of practice and not seeing complications in the absence of drains and breast reductions, I just choose not to use them. Patients are very happy to hear they don't need to have drains or have drains removed. However, in my explant practice, and I should say more specifically capsulectomy patients, where I'm creating a raw surface that may or may not have had free silicone in that capsule prior to the surgery, I prefer to use drains. I understand that by doing a total intact capsulectomy, I'm not exposing the new surgical site within the breast to silicone. However, I do know that it does weep fluid, and whether there's ruptured silicone or extracapsular silicone or bacteria or fungus in those capsules or in the breast tissue, I would rather see the fluid that the body produces over the first few days after explant be safely removed by a drain. Most of the implants that I remove are under the pectoralis muscle, and then I always repair that pectoralis muscle neatly and securely to the chest wall, which really reduces the amount of raw volume that could secrete fluid in that healing incision of the breast. But I still think there's value to the drain, and there are patients whose implants were placed originally above the pectoralis muscle. And there's really no effective way to completely close that pocket without a drain. And my concern is that if there were a fluid collection to develop, and yes, the body has the ability to absorb most of that over time, if a patient has a persistent fluid collection and they were to have it persist for weeks, you
Yeah.
could form a new capsule around that fluid collection so that even if you drain the fluid with a needle, you could still have a capsule lining in that breast, even though the goal was to remove capsular tissue. I'd also be worried about infection if somebody had bacteria or fungus in their capsules. And I was recently contacted by 2 out-of-state patients, one of whom from Ohio, who had explant surgery but had persistent problems with fluid collections and wounds that took months to heal, and another woman who had fluid collections down in Virginia that needed surgery to manage it, that is healing better now but also has a residual wound. So I think that the inconvenience of the drain is real, but it's small, and the potential complications of a retained fluid collection, whether because of the need for frequent drainage of it to help it go away or infection or sepsis, to me favors putting the drain in at the time of capsulectomy. If other plastic surgeons' experiences are different, I'm fine with that. I don't tell anybody what to do. If they're safely delivering the operation without drains, I'm happy to hear that. But I just have to do what I think is safest for my patients. And I'm happy to take drains out quickly. We talk to patients daily. If the drainage isn't that much, they may be back in 3 or 4 days for drain removal. I have patients that are traveling in from out of state, and they're going to stay as long as they need to for their initial early healing phase, whether it's 5, 6, 7, 8, 9 days after surgery. Usually it's on the shorter end of that range, but if there's a drain in place, you can be sure we're talking daily, because as soon as the drainage values drop off, I'm going to get that drain out, even if it means coming in on Saturday or Sunday to help get them back home as soon as possible.
Is the fluid amounts that the body secrete at the area of the chest where the breast implants were removed, is it related to the size of the breast implants?
I don't think it's related to the size of the breast or the size of the implant. It can be related to the degree of inflammation, the presence of gel bleed or gel rupture, the presence of bacteria, perhaps even disruption of lymphatic pathways in the breast by virtue of doing a capsulectomy. So I'm not going to have all the answers as to why in some patients they make little fluid and some patients they make a lot of fluid. I just want to have a mechanism for the patient that is making a lot of fluid that it safely exits as quickly as possible and get wounds to heal. We have the same debate in tummy tuck surgery, where skin is lifted up off the muscles of the abdomen to tighten the muscles. The skin is laid back down, and we need that skin to stick down as promptly as possible. I'm going to say most plastic surgeons use drains. There are a few that do drainless abdominoplasty. I'm a skeptic about that, but most people use drains in that circumstance, which is an analogy that's not terribly different.
Okay, so it's really better to be safe than to choose something that seems at first convenient, because we're only talking about a few days, maximum 5 days that you are attached to the drains. I certainly had it. It wasn't very convenient, but I'll choose the safe way.
And I can't make the argument that drains cause complications. It's extremely unusual to be able to really pin down a complication or an infection on the presence of a drain tube. They're placed sterilely in the operating room. There are just millions of drains used every year, and there's really no correlation or association with the usage of short-term drains with causing infections in patients. So that's not a real reason not to use them.
Perfect. So I think we answered that question about drains or no drains. And I assume that different doctors have different styles during that procedures.
And I have no problem with that. This is not a game-changing decision for many patients to have a drain or not. They're not going to refuse to go forward with explant surgery because the surgeon prefers to use the drain. It's a small point. I happen to think it's important, but it's not worth arguing too aggressively over.
Perfect. Thank you so much again. And I think we addressed that issue. I just find that it's so funny that because there is so much information in the media, that I can see more and more patients through the post that have a list when they come to the doctor. And they would say, doctor, listen, I don't want to have drains. I want to have minimal scars. So maybe you do that scar. And to me, it's a bit funny because it's almost like, I know that you're saying that's not a game changer, but at some point, I think that women like myself, and we are very educated, and some are more educated than other, you have to put the boundaries between telling your doctor how to operate in a surgery room.
Leora, I have a lot of respect for patients that come with a list of questions. They want to get it right. They want knowledge. They want to feel comfortable before going forward with a procedure or choosing a doctor. So I think that's great. And I'm not a rigid thinker. If someone said to me, I understand the pros and cons, you've explained it to me, but thank you. I just don't want to use a drain on this procedure. That's not going to prevent me from going forward, and I'm not going to impose upon the patient that it's my way or the highway. I think there's value. I have an opinion. I explain what process and my experience, and then we make an informed decision about what we're going to do.
Perfect. Okay. Thank you very much.
You're welcome.
And we're going to share this information. Again, if you like what you're hearing, please share it with your friends and subscribe. Thanks a lot and good night. Bye-bye.
Thank you, Leora.